Stanton here with ACEP Frontline here at ACEP19 in Denver, Colorado, joined once again by Dr. Joe Piktel. He's out of Cleveland, Ohio, and we had him on last year chatting about Research Forum, and we wanted to do the same thing this year because it's the best way to kind of get a head start on the things that may change your practice over the next year. So, Dr. Piktel, thanks for joining us once again here on the Frontline.
No, thanks for having me.
So, give us an idea. How's we've gotten another year under our belt. Where are we heading with EM research here at the forum?
So, we have a great lineup, and so the nice thing is we keep getting bigger and bigger. So, as ACEP keeps growing, we keep growing, and our research keeps growing as well, which allows us here at the Research Forum to have more sessions that include just talks about how research changes our practice, as well as presenting the best abstracts in their own sessions. So you really get the best of both worlds here.
And it's I'm going to actually release this one while we are here, so it's going to be the one that's recording it on Sunday morning. We're going to release it here on Monday morning to make sure that folks who may be here in Denver with us get a chance to maybe swing through and see some of the things and talk with you and kind of check out some of the stuff here. What do you think, and what I always like to pick your brain on, and it's a huge challenge, I'm sure, because there's just so much information out here of saying, okay, in the next 15, 20, 25 minutes, I want you to give me the highlights and just narrow it down to like a few of them. What are some of the big things you think that are going to be really maybe impactful even now or in the near future with emergency medicine with the Research Forum?
So it's great. So in emergency medicine in general, it's going to be with the Research Forum too, is that there are a lot of presentations on technology. There's going to be, how can technology help throughput? How can technology help, make critical decisions easier? How can they identify patients in the emergency department? So we have quite a few abstracts kind of scattered throughout the 3 days, more so than in the past, about things like machine learning, about things how computer programs can assess patients with the potential for sepsis, and give you an idea. How can use of different technologies decrease the number of medical errors? Things like that we've seen a lot of this year, which is pretty fascinating.
Do you think that we're getting to the point? I know in the past there's been can the technology on its own be anywhere near as accurate as the physician with the interactions and the not basic checkbox type characteristics of what the patient looks like in front of you, the characteristics of the everything else that we take in as the physician in front of the patient. Are we seeing now? Are those kind of saying we're finally getting to the point now that one, it's something that can really do most of the job, or is it something that's saying, hey, this is something that's really just going to basically augment our role and say, think about this, put this in your differential, this is this much percent of this, and really just be something as another tool, like the future stethoscope for us, something that actually just say, as part of this, we've got this much of a risk of these and these, and just kind of run them through there.
So it's a great question, and it's always any changes people hate. Everybody fears change. It's just how it is. Anything that comes, you're going to immediately dislike it. But it's funny you mentioned that, and so are they going to replace medical decision making? No, it doesn't. It's now getting to the point where it helps you work with your medical decision making. Meaning, and this is stuff that we've done all the time. We have clinical decision rules that have been created forever that says, okay, if we ask these 5 questions, in this particular set of rules, it helps us with our medical decision making. That's what the information now is doing, only in real time. And so it's giving you an alert. It's like, hey, like you said, this might be on your differential, to look at a sepsis alert, something like that. That changes in real time, as opposed to I use this clinical decision rule that I've learned from a manuscript, 15 years ago, and now I'm just doing it on the computer in real time. So it's the same. It's the same idea. It's giving us the opportunity to gather more information, risk stratify patients in a better way, so that we can make both better medical decisions and utilizations of resources in our hospital to help treat patients better.
What I'm seeing, and the interesting transformation in this, and I'm surprised it's taken as long as it has, with the evolution of the EMRs, the natural kind of data mining that runs in the background, so nothing is actually even a separate program where you have to plug in data like we do with many of the tools, many of the websites, the calculators, things like that. And then just recently on ours, we started having the background data mining for the sepsis risk, and it's something that you don't even think about. But then once you get in the order sets, will flash and say these things, and not just the screen that the nurses do, which drives me nuts in the front because it's so widely insensitive. I guess it's overly sensitive. It just has no specificity. But then it kind of actually goes into the background, looking at the patient, the vitals, the labs, the changes, and everything else, and starts to then pull things together and say, there's this much of a risk of sepsis at this point that it feels like, and it actually puts a number to it based on the data, and it's something that's always running in the background. I feel like that's going to be the big future. Is not something where we're having to go somewhere and put in separate data and data points, but with many of the tools, the goal is to have as few steps as possible. That way, they're easy to remember and easy to do quickly. But when it comes to having an actual computer program, you can put as many steps, as many details, as many data points as you want, because it's always doing it on its own. Is that kind of where things are leaning? Or are we going more towards something where we actually have to go in there and do our own data entry type things to kind of pull a number out?
No, I think we're getting lucky now, and so I think that initially, if you had to, if you had to continually input data into the machine yourself, you were losing time,
Right.
And therefore not your mind works better than that, and it can do it in itself, the whole clinical gestalt. But now the machines are simply improved to the point, and the information can be analyzed so much faster that the real time data is where it's coming, and we don't have to. Those data points are there. They're coming from the patient. They're coming from the monitor that's dumping everything into Epic already. That's doing it in real time. So we don't even have to be there. It notices it before we do, and then analyzes it before we do. I think that's where we're headed.
All right. What are some of the next ones?
All right, so the main thing, especially if this is coming out Monday, if you're hearing this Monday morning, please don't forget, come to our inaugural Brooks Bach lecture and abstract session. And so this is it's a CME-accredited session. It is the top abstracts, and is also in conjunction with one of the top researchers who is going to give a lecture for the first part, and then after a lecture about how research impacts something in emergency medicine, and then followed by that researcher then moderating the top couple of abstracts in the session. So this year we have Dr. Brennan Carr giving us a talk on acute care delivery in the United States. Don't hate the player, change the game, and that is going to be like I said, the inaugural lecture at 9 a.m. on Monday. And so don't forget. It's great because Dr. Carr has been working in both the Obama administration as well as the Trump administration in the Department of Health and Human Services. And so he kind of has as an emergency medicine physician and is able to talk to us about how all the different approaches to the attribution of emergency care, and why the future is something called co-optition, and how the public's priorities can be leveraged to improve emergency care. It's going to be a great talk. It's going to be something that you can't get anywhere else.
What are some of the other little take-home abstract points, high points, trends? We're getting to technology, that front-end technology, and I know some of our other podcasts are going to be some of the portable and evolution of the ultrasound technology. What else are we seeing from the research standpoint?
So, other sessions that we have we have sessions on research networks, and so we have a session how research networks can help us provide information, in a more global way. As when we're in emergency medicine, we're a single center, and we may not see everything we need to. When you have a research consortium or a research center and a research network, then you'll be able to pool expertise, pool more patients in order to study different disease states in a much better way. And so we have an entire session on how research networks has going to change emergency care as well.
That's going to be big. It's one thing that I've been thinking about recently is the fact that emergency medicine has been producing a fair amount of its own research over the last number of years and decades even, but it's now looking into the potential of bringing in these centers and networks, because we know that the big thing about research is, one, can you find significance, and then two, is it generalizable? Is it something that you can reproduce at other facilities? And if you get a heterogeneous patient population with multiple centers, multiple areas, multiple demographics, you're much more likely to find, if there's that proof of significance, or a change, or of efficacy, that it's actually something that'll likely be reproducible throughout the country. And with between EMF and other sources of grants throughout the country, I'm seeing a lot more now. I mean, there's recently huge grants, especially with the opioid epidemic, on things that are wanting more global application as opposed to things that are just more single site focused. And that's one of the challenges and restrictions with a lot of the research we do. It's just many of our shops don't have the appropriate numbers necessarily to find that, get to that level of significance without doing just a hideously prolonged study. And there's that paucity of information and data when it comes to certain relatively rare diagnoses, just because most places on their own can't get that level of significance. I mean, you may have a N of 20 or an N of 25, and we all know that, for the most part, that's not going to be the numbers necessary to actually get a quantifiable significant change, or detect something that is going to be of significant benefit to the patient.
No, exactly. And this idea of collaboration and using networks is not just in emergency medicine, not just in clinical, even in the basic science world, which is where I live. A lot of the money from the NIH is going into multi-PI, multi-prime investigator grants, where they're taking multiple areas, multiple expertise, in order to help kind of globalize the ideas and the trends that you're seeing.
All right, so what are some of the other things that we are seeing with regard to themes within the research forum?
So we talked about how how do you get the best data? But the funny thing is, how often is it changing practice? And so one of the we have a great session coming up tomorrow at 2 p.m. about caring for the patient with syncope, and we're looking at it under the eyes of, like, everybody sees patients with syncope all the time, and there's plenty of data out there on what to do with patients, but there's such a wide range of what people do with a patient with syncope, and it's interesting to see. All right, so what do the guidelines say? How do the guidelines start with? What's the definition of this disease process? What's the things we really want to rule out? What tests should we run? What's the risk stratification? What's the disposition? And how much it can change from person to person within a practice, let alone outside of a practice. And so we have an expert panel here to discuss what the experts say we should be doing, and why, if we're not doing it, why aren't we?
Well, that's a good point. That's a good point. Are we seeing anything in terms of progress of anything that's really going to impact therapy we're doing now? Of course, there's huge debate on sepsis. We're talking about that some. There's all these things. Is there something that, if you don't, or even something close to it, where it has the potential of saying what you're doing now is not what you're going to be doing if this particular thing pans out? Some sort of either new therapy, change in approach that we're looking at from emergency medicine.
So I think one of the interesting pieces to that is therapy is with the opioid crisis, and now everyone initially understanding seeing the concern, seeing the crisis, implementing last year was knowing that this data works using ED-based buprenorphine, or medical assisted therapy or treatment, from the ED works. But it wasn't but now we're seeing many abstracts on the implementation of that. And so things that changed from last year that says, oh, we should be doing this. Now we're seeing the studies on how we did it, and did it, how we did it in our institution. Because I think that last year was about changing the mindset of how to treat patients, and now people are I wouldn't say on board is not the right term, but now figuring out that once you figure out how to treat a patient, and you need medication-assisted treatment in your emergency bar, and how do you get there? How do you get from one place to the other? And so now we're seeing that. So we're seeing that therapy move to the next step. It's not just in that case, it's not just ordering it from a pharmacy. You have to set up a system. And so we're seeing a lot of studies about how you're setting up your system now.
With that system, is there anything that's now talking about the with this being a relatively new implementation with medication-assisted therapies, referral bridges, that sort of thing, are we seeing the research and data starting to come out on, kind of more global emergency department trends in terms of returns, failures, overdoses, whatever it may be, the questions people have of if I'm doing this, initiating it, because that's the big concern that I've heard from a lot of physicians that are really just learning about it is, I don't want to be part of the problem, so I want to know that what I'm doing is actually helping people get to, recovering successfully. And there's some research out there about the numbers and things that shows that how much better it retains them within treatment and within recovery and sobriety. Are we seeing more of that now on a global issue now that we're having more widespread implementation of the mats and things and bridges?
So that's a good question, and that's where all the rest of we were talking about coming in. So those studies are outside of the original, outside of real studies are the big ones. Are maybe aren't there yet. I think the idea of now setting up the centers, where a lot of the funding has become to setting up your centers and setting up a network of centers, in order to study the differences. I think that's where we are now. I think a lot of I think that's coming in the near future. To see exactly we've implemented this. It was implemented in the at an institution and it showed a benefit. Now, if we implement it on a more global scale, everybody wants to see the difference, and I think we're going to see it. But I think that would be the next great step, and so I think hopefully soon we'll see that.
With these, are these projects? Are many of them just are getting started? Are the things that looking for getting off the ground? How many of them are the really large trials that are with these things that say these studies are big enough or review enough to say let's make a change in practice, versus more of getting down there and of these young research, young researchers, even though it could be any age, but a lot of people getting their feet wet with EM research. How many of them actually are those that are like we can change practice versus how many are like that's an interesting thing? I wonder how that pans out once we get more larger scale studies done.
Sure, and so I think a lot of things you're going to see, of course, are going to see those first steps here. And so we're going to see, in our abstract sessions, you're going to see this is a great idea. Here's the first step of in globally any research, any clinical trials. This is the thing we need to do, and we'd like to do it on a much larger scale. And so in the abstracts, you'll see presented are going to be those first step sessions. The larger ones with the manuscripts that are out there and that kind of stuff. Those are like more of our highlight, or even the CME sessions, where it's like where the study has been done. The big study has been done, the manuscript's been put in, and now we're just reviewing the manuscript. Are the ones that you'll see at our CME, potentially at the CME sessions when we talk about syncope and we talk about that. We're going to review some of those larger articles that you described.
And what are you finding? That's a good one to even talk about. You're talking about syncope, and that's, we're just recently, a few years ago, we had drama alert, panic alert with the study that comes out that says so many of syncopal episodes actually result of PEs, and that may be the only symptom. So now all of a sudden we're doing CTAs, contrasted scans on all these syncopal episodes that are otherwise asymptomatic and have no other risk factors. Now, since that's come out, that's really kind of the follow-up research has not really panned out that that's anywhere close to the numbers of actual concern. Where are we moving with syncope? Because I know most recently we're hearing about the potential that there's really no benefit in bringing in these folks over 50, 55 that we used to bring in because of the potential for arrhythmia, because our outcomes are no different.
Exactly, and so that's one of that very specifically is going to be discussed in our session. And so the idea of first, what's your definition of syncope? And that's one of the things with that study where it showed 16% of patients who were undiagnosed syncope or who were admitted for syncope in the hospital had a pulmonary embolism. So that seems like a lot, but that's also kind of an association. And so what did they come in with? How did they have it? How long were they in the hospital? Were they symptomatic? Was it a large PE? Those things are more, did that PE cause a significant risk for 30-day mortality or some other significant prognosis? And so that's the questions that are answered when you have such a which is an interesting associative finding of say the PE. And then when you look back at it, you're just like, well, maybe that's not quite the, like you were saying, it's not quite the numbers, and that's going to be discussed too. The idea of so patients who are over 55, they still have a risk. They have a risk of of a 30-day mortality or arrhythmias. But is that risk mitigated by an admission to the hospital? So that's the real question. Can you change the risk no
Right.
matter what you do? And so if we can't change anything, why are we doing it? And so, is it helpful to do it? And so, that's going to be discussed too. We're going to have some of the authors of the study talking about that. It's going to be really interesting to see because there's a lot of questions there. It's like, are we not doing the right things in the hospital to change the problem? Are we, or no matter what we do, we can't. The admission itself is not a useful therapy, and so and if it's not, what is a useful therapy? So those are fascinating topics, especially when it comes down to, hospital overcrowding and things like that, where resource utilization. Everybody would like to think that if you admit somebody, at least from the emergency department side, it's like, well, I admitted them, so I'm good. My hands are I wipe my hands, I'm good. I did the right thing. But maybe not though. So like that's not potentially the right thing, and so we have to think a little bit further, I think, to decide what's the right thing for the patient. Are we changing the patient's course by our actions?
That is a huge question because at that point, if you're not changing anything with an admission, then your admission is actually purely just for one to help you feel better, and two, the theory of malpractice protection. Because if there's going to be a bad outcome in a week, a month, 6 months, a year in these patients, but it's going to happen no matter whether we admit them or not. Which is, it looks like the studies on chest pain. With otherwise normal unchanged EKGs and negative troponins and then the syncope, it seems like everything that's coming out now says admitting these that don't have anything of significant concern on our initial evaluation has no change in their outcomes. So really there's no reason to admit, and yet we still are, because of the malpractice environment that we live in here in the United States. At which point do we get enough research that it actually establishes what our concern is what's going to be called the standard of care,
right?
Enough that we can actually send these folks home and saying, listen, no matter if I keep you or I send you home, there is a 3 or a 5 or whatever % risk there is. I mean, if you're trying to admit people, one, thinking that it's absolutely going to help them, two, that you can get risk down to 0, I mean, it's not going to happen. And that's even the things we've heard most recently with syncope was the fact that number doesn't change significantly whether you put them in the hospital or not, and for almost all cases the evaluation in the hospital doesn't change the management or outcomes.
Right. So, and that's a good question, and this is where you're going to get a couple things. One, you're going to get a wide variety of practice, of course, right? There's providers who are going to accept that risk, providers who are going to want to change, not accept that risk, or not necessarily not accept, but let's say, well, maybe there's something else we could be doing. Maybe we're not doing it correctly. Maybe in certain situations that's the case. So there probably will be a time where the data comes out saying absolutely that nothing you can do changes. However, there also is now, as you know, so much. Now's the time to use shared decision making with your patient. Now you take the data that and you have your I can't help your cardiac syncope. Risk by admitting you. I can't. Well, let's talk about what the risk is, and let's talk about how we can help you. And if you talk to a patient that way, and they're just like, I can't get my medications, or I can't tolerate my medication right now, or there's some reason where you can't define the normal outcome, then maybe then an admission is helpful for them as you discuss it with them. If they say, if my risk is this low, no matter what happens to me, I'd much rather be at home. I have this and this and this, and I can follow up my doctor, and I can do that. That's a clear, perfect example of shared decision making. With the patient, that's going to bring all the data that we've had back to the individual patient, and in that sense, everybody feels okay with the outcome. No, nobody wants a bad outcome, but everybody feels okay with the decision.
Right. And there's honestly, we're all on the same road. We're all going to we're going to reach the end at some point. And so, I mean, we can't prevent that with every patient that comes in. And at the same time, I think the future in our strength in emergency medicine is going to be getting the research, getting the details, getting the data which allows us, one, to avoid unnecessary tests and evaluation, which I think some of the artificial intelligence kind of bolstering some of that data and information, pulling it all together, as well as research that can help us prevent unnecessary or avoidable admissions, getting people home, things like that. It may be that's where we have potential for high impact because we don't have because we can open up those bed spaces on something where there's not value added. And I think that the huge in syncope, chest pain, of course, working on the sepsis side of things. One of the big things that I think moving forward, potentially looking at in terms of risk, is the TIAs. That seems to be universal. We're admitting almost everybody who has that transient symptom, and depending on what kind of evaluation workup we can do, are the numbers there that says we can avoid most of them, bringing them in the hospital. And I think that's that kind of that holy grail. We're working with those high risk, what we would consider high risk diagnoses. Where can we reach those numbers and sensitivity and specificity to know who really needs to come in, who needs to go out with relative safety that's not enough to put patients at undue risk versus what they would have coming in the hospital versus going home versus whatever the traditional model that we're using now.
And how do you then disseminate that data? So if, I work at a tertiary care academic institution, and so I have these, tools as best as I can at, right at my fingertips. And so, but what about somebody who's in a smaller hospital? What about somebody who's in the community? What about somebody who doesn't have these resources available? And so, how can then we describe what we've seen and say, I can decrease my risk tolerance, and then tell them. And the more specific one is, how can my community ED that funnels through my main ED?
Yeah.
How can I tell the doc who's out there an hour away from me that wants to send me the patient, then how can I tell him that the same risk is, that risk is the same when I don't have, I'm not there. I have much more resources than
Right.
that physician. And so how do we create a system or a network of even our own emergency departments to improve this risk stratification?
I was looking, I've got it pulled up here. I mean, goes, how many is this? Man, there's hundreds.
Oh yeah.
I mean, they just keep
385.
385. Yeah, it's getting there.
Yeah.
Yeah, 383 is what we've
right.
got on in the actual compendium
Yeah.
that was sent out as part of Annals. Is there a way that folks can, there's so only a small minority of the patients of the folks that listen to the episodes are going to be here at ACEP19 in Denver, and obviously it's too late now. One, we're into day one already, and two, it's snowing every day while we're here.
Right. Good luck trying to get here.
Yeah, good luck.
If you're not here.
Yeah, good luck, everybody.
Yeah,
Get
right.
home as well.
Be safe. Yeah.
But is there a way that people can see the abstracts and see the studies and research, or is it the stuff that's going to be playing out that some will end up in journals at some point, some will not, but otherwise we just got to wait for the final product?
So no, you can. So the supplement that you're on is on Annals. Annals Emergency Medicine has a supplement online, and so it's a quick PDF. All you have to do is click on it. And so if you subscribe to Annals, you can get all of the abstracts. Now the presentation's a little bit different, and so the only way to do that is to get from ACEP On Demand will have our CMEs, but I'm not entirely. I don't think that they are videotaped into our to the abstracts themselves. And so, really, the best way is to look at the Annals supplement to help you.
I've always liked with this little compendium at multiple events, ACEPs. I've had this in hand for media, because media will start to pick up on a lot of these and start asking about certain studies and outcomes, and will that change practice? And we'll get calls, and then we're looking through the compendium here, especially when it was the print version that we would get right before scientific assembly. And now it's nice. It's long. It's going to be a pretty decent sized file. So if you have super slow internet, it may take you a minute to download it, but all of it's right there. Good. Few paragraph summary of each of these as they play through and kind of get the idea of where they are, because it's a great way to get an idea of where we are moving. And I think that's one of the coolest things about the research forums, whether it's here or elsewhere, is it really gives you an idea of where we are trending and where we are moving and what we're going to see. It's medicine's version of a crystal ball. And because a lot of the studies are more preliminary, they're smaller. I mean, some are the very large, but It really gives you an idea of the kind of the themes, the interests, the focus, the needs within the emergency department. Of course, you're hearing here about syncope, which is a big issue. You're hearing about the augmented technologies and artificial technologies that can help benefit us and grow and help give us more information and data at our fingertips without impacting our time, involvement, investment in that patient, which will help with efficiency and hopefully help with throughput, which of course is going to be a giant issue moving forward as our volumes around the country continue to grow. So I'd strongly suggest you get that. The ACEP members, you come in, log in your subscription there. If not, if you're not an ACEP member, you may have to find one and bum it off of them. I can't technically say that I said that out loud, but at the same time, it's a great way to get a lot of fantastic research that's here in Denver with us and stuff that will be impacting us in our emergency departments as we move forward. How can folks get more information if they want to contact you or they have a question about anything that they find and see on the compendium and on the data that we're getting here at the Research Forum?
Sure. If you're here and you have the mobile app, just send me a notification, and they can do that on the app. And so otherwise, you can email me at joepiktel, joepiktel @gmail.com about anything that's concerning any research or the Research Forum itself, or any of the research here at ACEP, and I'd be happy to either send a question along or do what I can to help.
And I mentioned earlier in the podcast that I was going to release this Monday morning. I'll actually release this later today, Sunday, just so to make sure, because you have that one that you talked about that's 9 o'clock Mountain Time tomorrow morning. And make sure as many people as possible have that in their mind, know what's going on. And if you're here and you want to pick up the data, make sure that you have all the Research Forum details and abstracts, that you'll have those before you head home, or especially if you have a chance to spend a little extra time at the airport, because all of us are going to be on delayed flights and travel on our way back to our respective homes.
Not a bad read. Yes.
No, you'll have plenty to take care of while you're waiting at the airport. As for me, you can contact me, youreverydaymedicine@gmail.com, youreverydaymedicine@gmail.com. I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.